If we could have the first slide, please. So I'll put this at the beginning because when it was presented to me, it was right at the end of a discussion. And obviously with Verkaufen, it was at the end of his life, and he'd wished he'd heard it at the beginning. And I think it's salutary to look at that, and good food for thought is that the thing that we can control is not giving bugs the environment. This thing that if you make the place, they will come. They will come. But if the place isn't there, they don't come. So the whole basis of what we're going to talk about with infection related to fractures is not giving them the place to come to. So I think they're not going to create the problem. They're going to take advantage of the issues that we've created. So the session is on trauma revalidation, as you know, infection related to fractures. We've had a few casualties, as you can see, but I'm pleased to welcome the panel who have graced with their appearance. This is an example of a desire path. So it's very hard to get people to do what they don't really want to do. So this is where I work. This is not a pretty picture of the JR in Oxford, but it is a picture. And it shows how somebody's made a path to go somewhere, but actually everybody else wants to go off slightly to the right, as you can see there, which was where the old footpath was. So they built the cycleway and footway, but people walked through. They put a hedge there, people trampled the hedge down. So people wanted to go that way. And if you try and get people to do something that they don't want to do, it's quite difficult. You see this with some nice guidelines. If you look at the take-up rate of them, they're not quite what you expect. And those of you in the NHFD session yesterday saw that still, despite what's been said, there's a tendency at the moment there's an increase in intramedullary nails being used rather than the sliding hip screws. And that reflects an underlying, I presume, a desire path on behalf of the surgeons. Interestingly, I think with the topic we've got today, we all know where we want to go. And I don't think there'd be much dispute. What we need is a path. The path isn't clear. We sort of meander around relating to infection and fractures. So the object of today is to try and lay a path down which people, I think, if it's there, will be by and large happy to walk on. What prompted this session? Well, last year I came along and I was at the British Limb Reconstruction Society session when they were talking about infection and fractures. And it was a much smaller audience because they were only allocated a smaller room. But it was really good. And there was one really good question that came from the audience when an SPR put up his hand and said, what should I do with a red wound at 5 o'clock on a Friday? So it wasn't about what should I do with 6 centimeters of bone loss in a pussed out limb or what, because by and large you know what you're going to do with that. You're going to send it to one of those guys who knows what to do with it and get it out of your hair. But the commoner problem that we've got is what do we do with something which is a bit iffy? And so we want to look at the whole panoply of it today. And when you look at it, you're looking at it from the point of view of your individual patient, because that's the person that you're dealing with, but also how is it going to relate to the community? How are you going to make a system that works for everyone? How are you going to get those things joined together? So the diagnosis of infection, well, it's difficult, isn't it? Because you've got this whole spectrum. From at one end, you've got no infection that you're pretty clear about. It looks absolutely perfect. And at the other end of the scale, you've got the worst thing that you can imagine. I'm looking at this down there. It's the other way around for you, isn't it? So the worst thing you can imagine. And you're fairly clear on that. And there's nuances in between. And you can populate that. You can populate that just from straightforward common sense. So that you've got an idea that and you know that if there's a suspected superficial infection, then quite often people will give a short course of antibiotics, splint, soft tissue stability or whatever, and we'll go on more about that. But there's a little group at the beginning that you think might be minor. There's something that your concern may be deep, and you're going to have a section in there of things that you might do, and you'll have a little algorithm in your mind for it. You'll have another little block of deep infection with bone loss or dead tissue, and you're going to refer to somebody who knows what to do. And you can lay those things out along your no infection to the worst possible infection. But there's gaps in between all of that. So even if you have it like that, there's uncertainty about what you do in between. But there's even more uncertainty, really, isn't it? So you copy the thing off your phone, that your graphic equalizer, and you think of all the variations that you might have related to a patient and a wound when you look at it. You could lay them all down like this. And you could, like you pick for auditorium or for base booster, you could imagine this would be good. If all of those were at that end, that's good. Clearly, if they're all at that end, it's bad. What the hell's that? And does it make any difference if it's that? Or that? Or that? And you look at it and you know there's every nuance that you can see in front of you. And for an individual surgeon trying to make those, it's hard to have any rational basis for it. So we need some sort of guidance. So how might we change things for the better? How might we build a road that people are prepared to walk along? Well, you can think about it in various ways. You can educate. You can educate, and you could give you a whole list of facts that you can see, and you can read that, and you might go away and remember some of it. But you probably won't. And if you do educate, I mean, what was shown with things like the BOA Congress guidelines for open fracture management was all that information went out there, and it didn't necessarily change practice in some places, particularly until there were other things put in place. You could, instead of trying to educate with everything, you can smatter with occasional facts. So the bit about Verkaufen, the bugs looking for tissue. So these things, I don't know where I first got these from, but whatever, they've stuck in my mind from a long way in the back. They're not part of an algorithm, but whether they're a single dose of cephalosporin can change the skin flora for up to 8 weeks. That sticks in there. So you start to, it makes you think about what you're going to do. Don't use the same prophylaxis twice. If you're trying to surprise a bug the first time, well, you're not going to surprise it a couple of days later if you do the same. So those things, whether they're true or not, I don't know, but somebody's managed to infiltrate those like a virus into my head. You can try coercion. So we've all had these people with clipboards looking around, making sure that you wash your hands the right amount of times and you do the correct things. You can give people a checklist, and we're used to that, and we do follow checklists. And we come back to this later, where that comes into the whole discussion. So, you can teach, this is a common mechanism of imparting knowledge. And if you've not done that physically, you've thought about that at various times. But then, really, you think, well, poor whoever that is that Robin, I presume, but how was he supposed to know what he was going to do? Because you probably didn't know really what you were going to do. So how did that person in the front line? And who are the people in the front line? You've got the people who might be in at the beginning of this. There's the patient. There's general practitioners, there's an emergency department, and there's the juniors on the ward. Those are the eyes and ears that you've got out there. So whatever we talk about in here today, if they have no idea about it, it's of no value. Because otherwise, if they have no idea, then you're in that situation before you've ever got involved in the patient. So whatever we talk about here, we have to impart that to those people in the front line, which is we'll come back to later. So Ian was going to talk about preventing infection and prevention of infection. There's not a lot to say. You're orthopaedic surgeons. You're really good at stopping infection. That's what you do. That's your day-to-day. You know that things will influence the infection, the patient's comorbidities, preparations, all of these things will be there. Why the hell should there be a difference between elective patients and trauma patients then? If we all know how to treat the total joint replacement in the elective environment, why should there be any difference to an implant being placed into somebody who's sicker, who's less well prepared, who's probably got more skin flora because they've not been washed before they go to theatre? Why should they have a different standard? So I think one of the lessons to learn is don't compartmentalize your mind into elective and trauma. In many respects, the elective patients are at greater risk, so there should not be a dual standard. There may have to be things that are done differently because there are pressures that you can't react to all of the time. But that shouldn't allow you to fall into the idea that there's a dual standard, and this group will get treated less well because they are emergency patients. So one of the things that Ian was going to say about how many of the patients on his unit, in the trauma unit, at one time were related to infection, and 20% of their beds had somebody with some infective complication, and they were on the same ward as the people who were having supposedly clean surgery for trauma. They were completely mixed. Well, you wouldn't tolerate that in an elective environment. What else can we rely on to help us with prevention? Well, there are some guidelines out there, because if you think of the groups that are most at risk, or that you'll know most about your infection, you've got the hip fracture group, which are the largest population of your trauma operations, and probably the bigger, those that are most individual risk are the open fractures. Well, interesting, in the hip fracture guideline, there was a lot of talk about practice, but none of it was related to the outcome of infection. That wasn't there. In the open fractures, the whole thing is directed at trying to get you to an end where you execute the initial treatment of the patient to minimize the later complications. And that's followed up in the NICE guidelines on complex fractures, which we'll talk about later. But there are guidelines part of the NICE guidelines incorporates this. And you can read that. And these are things that we can use as levers in the hospitals where we work to try and improve the situation for that group of patients. Because that's now has gone through the NICE process, has come out as NICE recommendation, and it empowers us to try and seek better treatment in the hospitals over which we have influence. And probably, as importantly, to get people to the place where they can receive that treatment if you're not in a hospital with an orthoplastic unit. If there is a multidisciplinary approach, it does seem to help. Our own experience in Oxford was that when the NICE guideline, when the BOA BAPRAS guidelines came out, there was very little change in practice. Our referral practice didn't change, and our ability to cover in at an appropriate time didn't change. But then as the MTCs came in and there was more rigorous control of the whole system, our time to cover and time to surgery changed, and our deep infection rate just plummeted. And there's been similar experiences at other places. Getting the right system in place does make a difference. It's not just pie in the sky. It's possible.